Okay, welcome everybody. Welcome to this Methods Hub seminar. My name is Tarani Chandola. I'm the director of the Methods Hub. This is our first Methods Hub seminar that we're having in person. Usually it's online, so it's very nice that you made the effort to come to this seminar in person. The seminar will be recorded, so it will be available to you and anybody else through the Methods Hub website shortly afterwards. So I'm very happy to introduce today's speaker, Dr. Hao Lo. She'll be talking about addressing bias in observational studies using real-world data. Dr. Hao Lo is an assistant professor in our Faculty of Social Sciences in the Department of Social Work, and she also has an appointment in the Department of Computer Science. Her research focuses on big data analytics in aging and mental health, looking at the nature and causes and consequences of critical health and mental health risks of treatment and interventions. So she's been looking at outcomes and conditions such as dementia, depression, self-harm, and suicide. And a lot of her work is about using large-scale electronic health records and administrative data to solve some of these mental health and aging challenges. So this is a research topic that is actually very close to my heart, and I'm sure you will be very interested in what she'll be talking about. I'm also especially pleased because Dr. Lo has a background. Her PhD is in statistics. And for those of us in the social sciences, it's all too rare to have a trained statistician amongst us, because they're so well trained, and usually we lose all the talented statisticians to the medical school or to the business world. So I'm very happy that Dr. Lo is with us, going to talk to us about some of her research and the methodological challenges. So whenever you're ready, thank you.
Really appreciate the opportunity, and thank you for Tarani for the introduction. I think he already gave very detailed introduction about what my research is about. I'm not going to say that again. But I think related to today's topic, my intention here is mainly to share with you my struggles, I guess. So I see some of, this is the first in-person session. I see a lot of familiar faces. So first, hello. So I want to talk about my pain. So for the past 4 to 5 years, I've been mainly working with electronic health records. These are pretty cool data set. I think some of you here have already have rich experience working on this data. And here I just very generally give a title, call it real world data. But for those of you who have strong background in social science, I think you may not be very, very familiar about what real world data mean. So first, I want to give you a relatively formal but also narrow definition. So because I just pulled it down from US Food and Drug Administration, and talking about what do we mean by what real world data. So according to their website, they're saying real world data are the data relating to patient health status or the delivery of healthcare routinely collected from a variety of sources. And these sources may include electronic health record. It sometimes include claims and billing activities if we're talking about US databases. And also in Nordic countries and also in the UK, we have very good disease registries for us to find information about. And in recent years, there are also patient-generated data, including in-home use setting, and also data gathered from other sources. For example, mobile devices and also wearable devices. So a lot of data sources can contribute to this real-world data. And in recent years, real-world data and real-world evidence are playing an increasingly important role in healthcare decisions. when we were talking about real-world data, I think there are some good qualities coming to my mind. First, I think the nicest thing about real-world data is readily available. So you don't need to convince your founder to say, I'm going to collect new data. Actually, these data have been routinely collected. As long as you visit the hospital, your data is there. And often we're talking about really large sample size. A lot of studies we have conducted easily goes to millions of individuals. We're not talking about millions of records, we're talking about millions of individuals. And then often we have very long observation periods. So in Hong Kong, just the data set we have been working the most with, for example, the data from public hospitals in Hong Kong have data available from 1993. So now it's 2022. We're talking about 30 years data have already accumulated. And then my struggle here, the disadvantages about real-world data. I know we're all social scientists. We're not new to observational data. So whenever we're talking about observational data, actually we shouldn't really talking about causal inference in a lot of occasions, because we didn't control, we didn't do really randomization, and we didn't manipulate in the way that randomized control trial should be. So observational data always have confounding, always have bias. And another thing is that data are not really collected for research purpose. So a lot of time, you may be interested in a lot of variables, for example, socioeconomic status, even basic information like income and educational level. They are usually not available in electronic health record. So these are things that you need to be aware of, what these data can do and cannot do. But anyway, even with this limitation, I think there are a lot of fun things we can do with electronic health record and a lot of important information we can generate. So when Tarani asked me to talk about some research that we employ interesting methodology, I immediately think about this paper that we recently published in August. This is a collaborative work. Especially I want to mention the first author of the paper is my PhD student who has graduated earlier this year, who has been hiding at the back. So if you have a very technical question about the statistical method, although I'm the trained statistician here, she can provide you a better answer. So here I want to mainly talking about the study design of this study, because if you look at the title, this is a very special study. We actually use 2 study designs ambitiously in one study. And in the process, there has been a lot of struggle, like which study do we really need to use 2 designs? Or which design should we talk about first? Because if you use 2 designs, the sample will be different. So a lot of challenges. The topic, I think it's good that the 10th of October is the World Mental Health Day. So here we're talking about whether antidepressant use will actually increase the risk of self-harm. So suicide is a research area that we have been doing quite a lot of research about. A lot of my research focusing on looking at risk factors associated with self-harm. So this is one of the risk factors we're looking at, a special one, which is antidepressant use. And I'm not going to talk a lot about drugs here, but I need to give you a little bit background information for you to understand why we're designing the study in this way. So there are 2 major questions. The first one is, are antidepressants safe at all? The concern here is that yes, antidepressants are recommended pharmacological interventions for patients with moderate to severe depression. However, clinicians have raised a concern. They have worried about there's an early activating effect during the first weeks of antidepressant treatment. And what do we mean by activating effect? Here, some example of the adverse events. There is a disinhibition, impulsivity, insomnia, restlessness, hyperactivity. All these may lead to an increased risk of suicide. But this is a kind of tricky thing to me because you're using antidepressant to treat depression, right? Depression itself is related to increased risk of suicide. And now you're worried about the treatment may also further increase of the risk of suicide. So here is the question, do antidepressants actually increase the risk of suicide behavior? So this is why we went through so much trouble to do complicated design to answer this question. So I already said, if a person have depression, the person will have increased risk of antidepressant prescription, and then antidepressant leads to suicide behavior. So this is the link that we actually suspect, but you have to tease it out from this direct impact. So how are we going to disentangle the effect of treatment from the illness itself? So if you have learned some epidemiology, you'll know that this is a typical problem called indication bias. That a lot of methods were designed to deal with this problem. So this is question number one. And question number two is which class of antidepressants? So there are a wide range of antidepressants available in clinical practice. And usually clinicians are advised to make the best choice by weighing their efficacy and side effects. And how complicated we're talking about. This is some interesting result that I just copied from a published study. The study published in PNAS is by a group of researchers. They put together all the real-world data together and try to look at what are the treatment pathways of different diseases. Treatment pathway means that, for example, the inner circle means what are the first treatment the person receives. And then the second outer circle is what is the second medication, because people switch between medication. And then it goes to third and fourth. So just as a contrast, this one is example of diabetes. I think this kind of plot might be a little bit strange, not so familiar to a lot of people, but it's actually very interesting and informative. If you look at diabetes, the majority of people at the first treatment will be metformin. So it's quite consistent, right? But if you look at depression, it's such a colorful visualization. The graph is beautiful, but actually means that it's a really complicated disease that has been treated by very different kind of antidepressant. And there are different classes of antidepressants. So you may imagine as a clinician and also as a patient themselves, you'll be worried about which antidepressant has the best performance in terms of efficacy and side effects. So there are questions at two levels. The first is, are antidepressants safe at all? Do they actually increase risk of suicide behavior? And the second question is, given there are so many different antidepressants, which one should I choose? Or which one carries the higher risk? Okay, and then I think for the first question, this is a research method seminar. I'm just putting the beautiful pyramid here for all the, I guess, first year RPG students. So if we're talking about are antidepressants safe at all, I think your first methodological choice will be randomized controlled trial, right? That will be the most ideal situation. You have a group of people with depression, and some of them, you give them antidepressant of any kind. And another group are the placebo group. They actually haven't received any antidepressant, and you compare them in terms of suicidality or risk of suicide. And good news is that there's already a study here published in BMJ in 2016. They already looked into all the data that has been submitted to U.S. Food and Drug Administration and did a very high-level meta-analysis on the top of the pyramid here. And they find that among, using data from 372, here called double-blinded, randomized placebo-controlled trials, they come to a conclusion that the relationship between antidepressant and suicide are highly age-sensitive. So if you are under age of 25, antidepressant is problematic. It does increase the risk of suicide behavior. Well, for people in the middle age group, 26 to 64, they find no association. And then for people older than 65, they find there's a protective effect, meaning that you should prescribe antidepressant to people as a first-line treatment. I myself is particularly interested in aging and mental health, so we really care about the older generation, the older population. And then for older population, the typical problem is that they're complicated. So a lot of time they have comorbidity, and they at the same time have polypharmacy. They were prescribed with different kinds of medication. So when they come to randomized control trial, you want your sample to be as neat as possible, right? So a lot of time, they have very strict inclusion criteria, and they will exclude people with comorbidity and polypharmacy. So the internal validity of randomized control trial, there's nothing to complain about, I think. But the problem is the external validity. Can we actually generalize the finding, the results, to a wider population that is more heterogeneous? So this is the problem. And here, as a person who's really interested in observational study, and we say that we're not advocating that we're using observational study to substitute randomized control trial. We want to supplement randomized control trial. So here you may consider cohort study or even case control study, observational study to provide additional information. And then, okay, now let's decide we're going to focus on a group of more complicated people to do observational study. And how are we actually going to design it? I think intuitively, the first solution that comes to people's mind will be, okay, I have a group of people with depression here. And then I'm going to define another group who have been prescribed antidepressants. And then another group with no antidepressants. And I can do some even further digging that among these people with antidepressant, we have drug class 1, drug class 2, drug class 3, as many drug classes as possible you can compare. And according to this design, we're including all individuals with depression. Do you see the potential problem here? Because at least in electronic health record, the reason why people were prescribed with antidepressant because they have more severe symptoms. So their dementia may be more severe than this group. So I put a classic picture whenever we're teaching about propensity score matching. We're going to put a picture like that here and asking you, are you sure you're comparing apple with apple and oranges with oranges? So this is a comparability issue, right? Can we really compare these two groups? I think the conclusion is that even though you do a lot of propensity score matching, it may still be challenging. Because by design, especially in our electronic health record, very likely people go to the hospital first, the majority of them will receive some kind of treatment, antidepressant, and leave very few people without treatment. And also their severity by default are very, very different. And then I'm just stealing some readily available information from this fantastic online book called The Book of Odyssey. So if you're interested in observational study, I have the link here and you can have a look. They have a lot of study designs there, and here another way to solve that problem is the cohort method design. So actually, when I decided to first, I gave up the first question. I jumped directly to the second one. What if I'm going to abandon all the people who don't have antidepressant, focusing on the people who already received treatment, and I'm only going to compare between drugs, so drug classes. And for example, this is drug 1. This is in epidemiology, we always said index date. So this is the date the person received their first dose of antidepressant. And then you follow this person for a certain period of time. So these are the whole period of time the person has received treatment. And if you want to know whether the outcome event actually happened. So this outcome event is self-harm in our context. And maybe there's another person also received treatment, but the outcome didn't really happen. And then you have a comparator group. Comparator group are not people who don't have who didn't receive antidepressant. Rather, they receive some other class. So they're all treated, but treated with different antidepressant. And again, you compare. And at this level, I still worry about, am I making everybody comparable? So can we compare directly? So here we have another procedure. We call it covariate capture, meaning that at the index date, I'm going to trace back, look at all the information that's available in the electronic health record, including the person's disease history, drug history, social demographic information, age, every information that I can find, and I'm going to match these characteristics. So this is another way. But wait a minute, we didn't solve the first question. So if you just compare antidepressant as a general class, is it safe at all? That question still hasn't answered. And then it comes to another study design, which I think is relatively new to the majority of you, because even for myself, it is new. There's not some method. When I was doing PhD, my major is structure equation modeling, really not anything about epidemiology. So these are a lot of things that I have learned from collaborators and existing literature. So this is something called self-controlled case theory design. I think from the name, you may already guessed, I'm going to use myself as control. So how is that going to work? You just divided a person's whole long life history into different periods. So for example, this is person number 1. In the very beginning, there's no exposure, no drug, no treatment. And then target means the person is treated. And then stop the treatment. There's no prescription of any drugs at this period. And this is the second person. Again, the medication is on and off. So another situation, unexposed, exposed, unexposed, exposed. So I divided a person's life history into different sections. And for each section, I'm going to look at the risk. Did self-harm actually happen in that period? And what's the incidence rate in different periods? So this is the basic idea. And this method is not entirely new. You can see that the literature comes from 1995. It's just not so popular, I guess. It's very popular in pharmacological research, not really in social science. But now I'm just thinking, when I was looking at it, I think these are situations that, if you think about social policy, exposure to social policy, I mean, it can apply, it can translate. So this is another design. So after looking at all the possibilities, this is our study. We're focusing on the middle to old age people because for the youngest age group, 25, the evidence is already very strong. So there's not so much gap here, and we're focusing on people 40 years or older. And we decided to use population representative electronic health records in Hong Kong to look at 2 questions. The first, we want to examine the association between antidepressant and self-harm by comparing self-harm risk before and after antidepressant treatment. So this is the self-controlled series design. I'm going to do within person. What's my risk before? What's my risk after? And then this is more like between person comparison. I want to compare what's the difference between different antidepressant classes. So these are the 2 study objectives. And then the methods. So I want to talk a little bit more about the data set. This is something our best friend called Clinical Data Analysis and Reporting System, CDAS. The data set is maintained by Hong Kong Hospital Authority. I think most of you here know what Hospital Authority is. And it manages all public hospitals in Hong Kong. So in total, there are 47 public hospitals. So here we're talking about population-based data. As long as you have visited public hospital, your records is there. Although we cannot identify you, don't worry. And then CDAS has pretty rich information. It has information on people's demographics. It does have age and gender. Sometimes it has educational level, living status, and occupation, but you can imagine this will not be as accurate as a social survey can be. And then we have clinical diagnostics and hospital admission and discharge. So you know when the person visits the hospital, when the person is discharged. And you also have the prescription records. And for this study, here we call it cohort entry period. So a lot of this study, we like to use the term cohort. So the cohort is all the people we're interested in. The cohort entry period is from 2003 to 2015. So among quite a long period. And the inclusion criteria is that the person has to be 40 years or older at their diagnosis of depression. First, of course, they have to have a diagnosis of depression using ICD codes. And also, we focusing on people with a new prescription of antidepressants because basically we already concluded that if the person do not have antidepressant, these are relatively milder cases that are not really comparable. So we focus on people who actually receive the treatment. And then here are some, I think, also beyond me information. We're looking at antidepressant at different classes of antidepressants. And here we compared 5 classes, the popular broader categories. The reason we classify it like this is not only because of this clinical relevance, it's also we have to consider the statistical power. You cannot have a specific drug that has very few people who are prescribed, right? We don't have data to follow these people. So these are the different drugs that we're interested in. And then here, apology for the small font. So here is the study cohort selection procedure. So whenever we're using real-world data, we always come up with a complicated graph like this to show how did we reach our final sample size. We started from, so this is the initial sample size. We have 68,000 people who have depression diagnosed in our data set. Looks big, but actually, if you think about these are data coming from the total Hong Kong population, it's actually not very large sample size because the number is actually similar to severe mental illness like schizophrenia, which shouldn't be the case. So I'm already telling you the limitation of this data set. We are looking at people, this is to show that not all the people with depression are managed by public hospitals. So there are also community clinics, there are also private hospitals, so we actually didn't cover that group of people. And this is another thing, usually when I'm teaching, I would say big data doesn't mean representative data. It's population-based, but the population means all the people who visited public hospital in Hong Kong. So this is where we started with. Nevertheless, it's still a pretty big sample size. And then we excluded those with index date in 2001 or 2002. Another problem is that in the electronic health record, there's no one tell you this is the person's first record. So a lot of time you only see a code, right? You don't know whether this is the first, second, which code it is. So what do? You have to trace back to all the years record. And if you look back for 5 years and this code didn't happen, you will assume that the code in 2003 is the first record. So a lot of time we have to use some kind of screening period to not make sure, but to maximize the probability that this is the first record. And then if a person received more than 2 classes of antidepressant, we're also going to exclude them, because if at the initial stage already a mix of drugs already indicate it might be some complicated cases. So we're also trying to narrow down to comparable samples. And then afterwards, our cohort analysis have about 48,000 people. The majority of them, 2/3 of them, are aged 40 to 64, and 1/3 of them aged aged 65. And then another thing, another step is that we have to further limit our sample to a eligible sample to do self-controlled series analysis. In this very painful procedure, at least to me, we lose 44,000 people. Why is that? Because you're comparing risk before and after, right? So you have to focusing, so for self-control theory, you have to focus on people who actually had a self-harm event. If the person doesn't have self-harm event at all, what are you comparing, right? Before the event, no event. After the prescription, no event. There's no point. So, and then after restricting to an even smaller population, which left us only 3,800 people. So it's just a lot of situation we ran into. I think also for survey study, you started with quite a big sample size, and you just apply your inclusion criteria. It gets smaller, 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 and this is our eventual sample. So what's left? We would be happy to look at specific drug, but we feel it's not sufficiently powered. So in the end, our main analysis look at antidepressant as a general, a broader class. And here is some, I think, more formal illustration about what self-harms, what self-control theory design look like. So here, again, you can see this is a hypothetical person. A hypothetical person's life journey. So first, this is a period that nothing happened, right? There is no drug, there is no prescription. And then I think the most important period is this period I colored called index exposure period. So we're interested in whether the person actually have an increased risk of self-harm at this index exposure when the person was prescribed antidepressant. But there are some other critical period. For example, the period right before index exposure. We call it pre-exposure period. This is a period so the person started to initiate antidepressant, right? Highly likely the reason is that the person showed some symptoms, right? And then the person started to seek help. And then the drug was given, and then you enter the index exposure period. So this is the pre-exposure period is pretty sensitive. And then assuming that the person stopped, and later it started another round of medication treatment. So this is a hypothetical, it's simplified situation. Actually, the person can go on and off, but we just summarize all the post-exposure period, subsequent experience altogether. So what we're doing is that we're going to calculate the incident rate of self-harm at this reference period, and then the incidence rate at pre-exposure period, index exposure period, and also subsequent exposure period. We just compare them. That's it. Idea is very simple. The model is not that simple, but I'm not going to talk about the details of the model here. I'm only going to share the design. So if you're interested in this method, I put the link of the paper here for you to study. So this is a paper published, I think, in 2016 on BMJ. There is a research method and reporting session. We're very, very good, very pedagogical, as tell you how to really run a self-controlled case theory method. And here I just quickly summarized the good thing about this method. We implicitly already controlled for the time invariant confounders, because you are, for example, genetic effect, for example, socioeconomic status at baseline, and health condition at baseline, you're comparing with yourself, right? So the risk has already been controlled. But a disadvantage is that only those people have both exposure and outcome of interest can be included. So you're working with a much, much smaller sample. That is research question 1. And research question 2, we still want to try to look at what are the between person difference between different antidepressant drugs. We have 5 classes. 5 classes that for me is very difficult to name. So there are 5 classes, and then we're actually, it's more complicated than only 2 groups analysis, right? If you have 2 groups, you just match once. But if there are 5 groups, and I want to do pairwise comparison, right? You have 5 groups, I want to compare 1 to 2, 1 to 3, 1 to 4, 1 to 5. We actually did that. So a lot of methods, these are complicated methods to accompany our need to do this pairwise comparison. I don't intend to talk about what exactly is inverse probability of treatment weighting, although this is actually very, very common. This is something we learned new about the generalized boosted model to calculate the propensity scores. And then here, just give you some information. Remember the first graph I showed, we have to capture the covariates, right? And what are the covariates we literally captured in this study? We look at the gender, age in years, living status, educational level, family history of mental illness. Basically, we digged out all the available information in electronic health record to control. And then we also use the self-harm behavior, antipsychotic use, and psychiatric and physical comorbidities before or at baseline. So we propensity score matched all these information and gave a weighting of the individual and then did the comparison. And for this study, the index date is the date of the first prescription. So after I've said so many things about it, I would like to say this is still a very simplified design, right? Because you know that people have medication come and go, but here we're only looking at the first prescription. What's happening afterwards, we ignored it. And also, we didn't really look at the dosage and the duration of the prescription. That's gonna be a very long project to really code all this information. But anyway, this is what we have done so far. And then these individuals were followed until the end of 2016. So they were followed until the occurrence of self-harm or death or the end of study period, whichever come first. And more importantly, we have stratified into 2 age groups. As suggested by the randomized control trial, the relationship is highly age sensitive. So you need to do subgroup analysis, which may be in opposite directions. Okay, and then here are the specific statistical model involved. For the self-control theory, it's estimated from conditional Poisson regression. Cohort analysis is the widely used Cox proportional hazard regression. I think these are too much information. I'll just skip the evaluates. So here is the result. Apologize for the very, very overwhelming result because we have matched a lot of things. But I think it's just you have to have a look at what are the sample size available under different classes. The majority of them were prescribed this class SSRI. Some prescribed TCA, and some prescribed NASSA. When I was presenting this study to some colleagues in Finland, actually they spend a lot of time just reading this sample characteristics because they find that just looking at the prescription prevalence is very different. So what is the most frequently prescribed drug is very different in Finland and Hong Kong. But unfortunately, I'm a statistician. This difference doesn't ring a bell to me. But anyway, and then we look at the majority of them are female. And then we also have some living status information. And you see educational level, the majority of the, actually not the majority, one-fifth of the individuals, the education information is missing. And actually this is much better than we expected. Because for some other condition, the missing is even more serious. Okay, and then this is table 4.1 continued. So we have another set of covariates, includes psychiatric comorbidity and physical comorbidity. A lot of things, we also match them. And then here is the maximum pairwise standardized difference before the matching and after the matching. And if after the matching, the number is still 0.1 or even more, that means the matching is not very successful. We're going to continually control for this variable in the subsequent model. And we also have crazy tables about age after 65. I'm not going to present it. I'm going to talk about the main result. So first is the result from a self-controlled series analysis. So I think I put a figure here just to remind you, because I think when I first see these graphs, it doesn't really clear to me which period it is. So first, these are the reference period or the baseline period. And then I just put, so this is a pre-exposure, index exposure, subsequent exposure. So you would imagine the most important information we're looking for is the index exposure. We're worried about after the initiation of antidepressant, people may have increased risk of self-harm. And what you find here is actually a little bit tricky. So if you compare with baseline, yes, it does indeed have increased risk of suicide behavior. So 7 times more. But what about this period? This is the very sensitive pre-treatment period. Meaning here, people have much higher risk of self-harm. So this may be the very reason they get an antidepressant prescription, because of their depression symptoms. And then technically after this period, the risk is actually decreased. So if you compare with baseline, it seems like increase, but if you compare with pre-exposure, it's actually a decreased risk. So the conclusion will be at least it didn't increase risk compared with the pre-exposure period. And this is the pairwise comparison. So if you look at here, we have so many lines, right? We already excluded the information of the covariates, just reporting the key information, the pairwise comparison. So we have different drugs. In total, there are 10 pairs because we have 5 drugs. And then you compare them one by one. Actually, not so many of them are significant, meaning that there are not such a big difference between drugs. However, you do see, for example, here, NASSA has increased risk associated with increased risk of self-harm in comparison with TCA. The increase after adjustment is 2.1, it's 2 times increase. And then another class is 1.6 and 1.7. But if you look at people who age 65 years older, the difference can only be spotted between 3 pairs. For example, here, and also SNRI as SSRI, and SNRI and NASSA. So not so many difference, but still there are substantially and significant different spotted even after we did all the propensity score matching and further control of covariates. So here comes to the conclusion. So first, if we're talking about within person difference, we did find an increased risk of self-harm before and during the exposure of antidepressant compared with baseline period. So this we have to acknowledge. But the pre-exposure period showed a higher risk. This suggesting that the self-harm might be an indication for antidepressant treatment only. It doesn't really increase the risk of self-harm. And then if you look at the between person, we find the risk of self-harm varied between certain pairs of different classes. And actually in the paper, there are very long discussion about the implication about which pair of drug and why this is higher and compared with previous study. But I think that would be much more interesting for students have pharmacy background. So last but not least, we find a consistently lower self-harm risk following the initiation of antidepressant treatment in both age groups and all drug classes studied. So we did some subgroup analysis. First, this is only focusing on TCA, another focusing on SSRI, but it's too many information. We just put it in a supplementary. But all of these actually support the hypothesis that self-harm behavior is triggered by the core symptoms of depression itself, rather than antidepressant use. At least I think we provide some additional evidence to this older population that antidepressant is not dangerous, and you would have been worried in children and adolescents. And so just from a methodology perspective, I think studies like this offered a very important supplement to randomized control trial. And what's the issue of randomized control trial? We have summarized here. It is often limited to a small number of events, right? Because usually randomized control trial is very neat, but it doesn't have a very large sample size. And when you're thinking about very hardcore outcome as self-harm and suicide, if you start from a sample of 100, how many of them will actually commit suicide or have self-harm behavior? And so you see, we started from 60,000 something, right? And for those who actually have behavior, it's only 3,800. So you have a big shrinkage of samples. So which means randomized control trial is very challenging when it comes to outcome that is relatively rare, although very serious but rare. And when you summarize different randomized control trials, there are also inconsistent measures. For example, how are we going to quantify suicidal behavior? Some study using scales, right, to quantify suicide intention. Some study focusing on suicide behavior. Some is just self-harm history. So there are differences. And a lot of randomized control trial, you cannot follow people as long as 13, 14 years, right? And then it also, the most serious issue is it deliberately exclude people at high risk of suicide because of ethical concerns. So even though you're studying suicide, but you're worried about these people have really high risk, I'm not going to include them. But observational study, on the other hand, is useful, but they are susceptible to confoundings. We have tried very hard to reduce bias. The most important thing, I think, is indication bias. We used CCS design, and for the cohort analysis, we also restricted people to those who were treated with antidepressant, and we used some complicated method to estimate propensity score. And I didn't really have time to talk about residual confounding. I think I can say a few words. This is something called E-values. I don't know how many of you have heard about it. This is also relatively new. I think I started to use it in these 2-3 years. In electronic health record, there are so many informations that we want to collect, but we don't have, right? And then what's the problem? The problem is that always reviewer will write a letter to editor or something saying that you didn't have psychosocial information, you don't have this and that factors. And what we do is calculate something called E-values, and basically it tells you that you hypothetically how strong the effect of other confounders need to be for your significant results to be explained away. So if you look at here, so we have, for example, here only 3 significant relationships, these 3 pairs. And only for the significant variables, we reported something E-value, meaning that only if the confounding and the self-harm relationship needs to be as large as 2.7 for this to be not significant anymore. So the e-value, the larger the e-value, the stronger your relationship is. So meaning that the confounding needs to be super, super strong to beat you up. That's the basic idea. Again, you can read new publications about how exactly e-value is calculated. But of course, these are just statistics tricks, I would say. They cannot really substitute the problems of lacking of confounding. However, as we said, biases and confounding might still exist. The most important confounding, a lot of time we don't have a measure of disease severity. It applies all diseases in electronic health record. We don't know how serious depression is. And we just assume that antidepressants were used to treat depression. But it may not be true, because sometimes it can be prescribed for insomnia and anxiety. Maybe just indication is wrong. And then we considered still, although 5 categories end up with 10 pairs, you still actually have much detailed categories that you can study. We consider rather broad classes of antidepressant rather than individual drug because of sample size limitation. You can go deeper and more details. And I can go on and on to talk about limitations. I'm not going to undersell the study anymore. But a lot of limitations related to the problem of electronic health record. So just to summarize, there are some key aspects regarding the research method. I think just throw some keywords here. It's not very pretty though. So first, this is observational study, which suffer from a lot of common limitation of observational study. This is a study using electronic health record, so usually we'll have pretty big sample size, but don't have enough number of variables. And this is retrospective, meaning that we didn't really design a study and look ahead. This is a cohort study, and we used 2 design. One is a Cox proportional Hazard model, a cohort study design with propensity score matching, and the other we use self-control series design. So these are the keywords for those of you who are interested in research method you may need to look into. So this is everything I want to say. I hope this sharing will help your research. Okay, thank you. Can I sit here?
Thank you so much, Dr. Lowe. That was great. I learned so much. There are all these new methods that I didn't know about. So thank you so much. That was really informative. We have time for questions. So please raise your hand and ask away. While you're thinking about a question, can I ask a very general question, which is about the data sounds really complex and messy. And how long did it take for you and your colleagues to get the data into a state where you could actually run some analysis?
I think Chai is here. She's the one who actually did the heavy lifting, the most time-consuming job. So I think this is actually the first study of her PhD thesis. So definitely some project you can manage during your PhD. So it's kind of tricky. So the data is, we're collaborating with collaborators from pharmacy. So for this specific study, the data set has already ready. It's been there. But there are other studies that we have to retrieve the data ourselves. My own experience, if you are retrieving a cohort of quite large amount of patients, it typically needs 1 year to retrieve the data. So it's actually quite time consuming. Of course, you can also write proposal to hospital authority to buy the data, but that may actually take even longer time. Okay. Yeah.
So please, don't feel shy. Please ask away. Yes, please.
King Hua from Journalism and Media Center. Thank you so much for your presentation. Very interesting. I enjoyed very much. I have a question. I try to understand the research design, how to really how it works. So I remember at the very beginning of the presentation, you have the slide to show the impact of depression and antidepressant on suicidal behavior.
Yeah.
So you try to have a design, you try to disentangle two effects. Okay. So then in your design, you try to compare two periods of time in your self-control period, which is the pre-explore and the explore period.
Yeah.
So because the explore period is with the antidepressant and the pre without, so that you compare.
Yeah.
But if you want to disentangle the effect of depression, are you assuming both period of time they have same level of impact of the depression on the suicidal behavior? Otherwise, how can you disentangle the effect of depression?
I think, so first, when I draw the triangle there, that is the ideal situation that you really want to tackle, right? And if you really want to solve that problem, you have to use randomized control trial.
So basically, your design
We are
cannot.
not solving that problem.
Oh,
We're just
okay.
going backward to say, oh, what if you cannot solve this using a randomized control trial? I'm going to just compare myself before and after. And of course, for both of this period, you assume that you have similar risk of self-harm behavior due to depression. Yeah.
But, okay, thank you so much for answer. But I have another theory that basically because they are decreasing risk of depression, because, for example, the person was divorced at the very beginning, so that was a high risk of depression. But after 90 days, they took drugs, and then they exposed to the risk of the drug. So, but you see the higher risk during the pre because of the closer to the risk trigger, because of the divorce, rather than because they are comparing both. So that.
I think this fell into the other limitation that you cannot really control for the severity of depression, right?
Okay.
Because, of course, we assume the diagnosis of depression always there. But, of course, as the disease deteriorates or gets better, the symptoms will change, right? It's actually the symptoms, the deterioration of symptoms may increase the risk of self-harm. So that is things that we cannot really solve in the study. So that is in the limitation.
Okay, last quick question. Why 90 days? If you shorten the delivery period, would you get, do you need to do some sensitivity analysis?
Yeah.
Okay, thank you.
Good question. The problem, we struggled a little bit. So we look at previous literature, and most of them use 90 days. And you can also look at 30 days. Yeah, you should look at, do sensitivity analysis and to see what's the effect. Yeah.
Thank you so much. Please, some more questions. Don't feel shy. Any question would be great. So if you didn't understand anything, please raise that.
Dr. Loh, thank you so much for this very enlightening presentation. I'm particularly interested in to know why did you do this three subgroup, like you had the TCAs and the SSRIs and the NAS SNRIs, and then you club the others as the two as others. So why not have 5 into 5 and have 25 against 10? So if you had these 5 groups and then you compare, so you would have 25.
Oh.
So why did you have this 3, then come up with the 10 sets?
So, for example,
What was the rationale behind that?
yeah, I think the order of the drugs doesn't matter, right? Because say if you have SNRI, compare with SSRI, compare with the other way around, just one, you may look for a hazard ratio that's greater than 1, the other is smaller one. So I think 10 is already all the possible combination there.
Okay.
Because the order doesn't matter.
As in you had the others, so I want to know what was the others, what did the others include in them? So you had a group which said others.
Oh,
So the others was the other 2 groups?
no, the others, so you have, say, antidepressant class, you have so many classes, actually. And then we're only looking at the broader category.
Okay.
So you have SNRI as major category, SSRI as a major category. So these are common categories. A lot of study, if you look at antidepressant, they look at these categories.
So you had these three major categories and the rest you...
Yeah, the rest, we
Yes.
don't know how to place them and
Oh, okay.
everything in the others. Actually, not so many people in the others group.
Oh, okay. So did you have a baseline that you compared the others with, or did you compare everything with everything?
So I think, yes, I think that's what we did.
Yeah, I think you compared everything with everything against having one baseline and then comparing
Yeah.
others with that baseline.
Yeah,
Oh, okay. Thank you very much.
thank you.
Please don't feel shy. If you don't ask questions, I'll have to ask questions. Yes, please, yes.
Hello. The reviewer asked the same question. Yeah, it totally makes sense. I think in some other study, for example, I'm doing dementia, and then the clinicians were suggesting, since there's no severity of dementia, let's just look at the drug they're using and the dosage and use it as a proxy to separate the severity. So that is definitely a direction to go. For this study, it's already complicated enough, so we didn't go further. I think the next stage, definitely the next study, if he still is interested in doing it, we can look into the dosage effect. That's the reviewer also asked. So treat the dosage and also the duration as a time variant variable to look the details. So there are so many more studies can be done in the future. Yeah.
Yes, please.
Hi, thanks for the interesting study. Suppose my which is the co-treatment. Typically, a person being prescribed antidepressant may be referred to, let's say, clinical psychologist or counseling. Maybe there's part of limitation, but that may play a very significant confounding variable. That's one. The other one I was thinking also about adherence. A doctor may prescribe the antidepressant, right? But the patient may not be consistently taking their medication. Yeah, I mean, this comes from my own experience working with people with depression, and these are the very common issues about drug usage and also co-treatment, where your social workers or counselor intervening, and therefore the risk for, let's say, self-harm behavior may not be as severe or whatsoever that it is. So that's one part. The other part is, what would you suggest then in terms of the clinical implication or clinical practice implication for both medical as well as non-medical professionals?
Okay, thanks for the good questions. So first about I think other treatment, definitely there will be an effect because I think if you look at the characteristics tables, there are some conditions that even you try to calculate propensity score, it still fail to do the matching. That means that these kind of condition may have some effect. And I was looking at it, for example, anxiety disorder, and for example, stroke. So I think there's some relationship between stroke and depression we haven't really taken into account in this study. But on the other hand, statistically, we adjusted all the covariates priorly and at the baseline. Of course, we didn't adjust for all of them. As you can see, there's one page, right? So each of the psychiatric and physical condition, I think, is mainly from previous publications. If they have worried about this, maybe the confounding way included them. So ideally, this should be adjusted. That is now the research question, rather a control variable. Yeah. And the second question about adherence, I think now I'm thinking our wording wasn't been really careful here. I think because we use antidepressant Some study will be very strict, say is antidepressant, did I say antipsychotic? Antidepressant prescription. Yeah, so use may be different from prescription. The adherence issue is always there in electronic health record. We only know that these drugs are prescribed, but we don't know whether they're used. So this is a limitation. And the third is a clinical implication. I think this is actually one of the clear ones among all my studies, because it's whether you should prescribe it to patients, especially older patients. At least the result of this study that you shouldn't worry too much, right? Because it didn't really increase the risk. And also for different drugs, and if you're really clear about the implication of specific drug types, there are differences have been spotted. But we would like to say that, again, this is observational study. And for some of the specific drug type, I still think they're not sufficiently powered to, or well controlled to give a clear suggestion to say that, oh, this drug you should prescribe compared to the other. I think you need more careful, more in-depth study to have that conclusion. Yeah. Thank you. Thank you for the questions.
Well, yes, please.
Thank you, Dr. Luo, for your wonderful sharing. I'm actually a PhD student from business school, and I'm also doing some healthcare analytics, especially for stroke patients. I have been working with Beijing Tiantan Hospital in mainland China for a very long time. So I have two questions regarding to their database. First one is for the EHR by the hospital authority in Hong Kong. Are the patient data de-identified? So how do you track for, this is actually an issue in our data set for my research projects, because all their user ID is random generated when they visit the hospital. So actually, we cannot track their long-term behavior for the data set, although we have a huge amount of data for the patient. I'm wondering if this is like the same for this data set. And also, as you mentioned in the flow chart, you actually lose a lot of observations for 60,000 to 1,000, right? So what is the missing values for the variables you use in the data set? Is it very large, or it's fair enough?
Okay, so for the first question, all the data are de-identified, so we don't know who the person is. But good thing is that as long as they're in the system, they were assigned the same reference.
Oh, the same, okay.
It's the same, so we can track them. We know it is from the same person, but we don't know who that person is. I think hospital authority also has some rule. If you do have rare conditions, they will not allow you to retrieve data for those rare conditions. They have to prevent them being identifiable. But for depression, it's fine. So many people have depression. My condolence for the data set. Because I understand that because you have a lot of data, but if they cannot be linked, that's really problematic. And then about missing value. So my flow chart, I'm losing the sample mainly because of either they may have problematic record, or they don't fulfill my inclusion criteria, which I define specific period. If they have diagnosed before that or after that, they will be excluded, not because missing value. Luckily, if you talk about missing value, most are in the living status, educational levels, demographic information, there are missing value. But for diagnostics, there is no missing value. So not no missing value. So if they don't exist, you treat it, the person doesn't have a disease, right? So that is not the.
Thank you. I also have some more questions. So, this question is a follow-up with the question before. So I'm also wondering, you define the pre-exposure period as 90 days, and the risk is actually very high compared to the reference group. So is it because is the risk is higher is because of the length of the period, or no, it's
The period should be already adjusted for.
Okay.
So because as you divide it by person years,
uh-huh.
yeah. It's mainly because the reason why the persons or initiated some treatment because the symptoms deteriorate. And likely they were prescribed because they have self-harm behavior.
Yeah, so actually for their first prescription date, the index date, is there any way that they can get the prescribed drugs other places, or this is defined as the accurate prescription date?
We only have information from public hospitals. If they have antidepressant prescribed in private hospitals or some other sources, we don't know.
Okay, thank you.
Could I ask a question about the self-controlled case series? It's so interesting. When you were talking about it, I was thinking, oh, it sounds familiar to like within-person fixed effects models, but it seems like it goes beyond, because the within-person fixed effects treats each occasion, averages out the effect of each occasion, whereas this method seems to distinguish between the timing of exposure periods. So is that a fair thing to say, that the fixed effects model doesn't really go into the timing of the exposures, whereas this method goes into the self-controlled case series, plays more, allows you to make inferences about the timing of exposure periods?
I think first I have to confess I'm really not expert of self-control series design. I'm really learning it. It seems like the base is a Poisson regression.
Yeah.
So you're treating at in certain period, what's the probability of event? So that is already, I think, to some extent that you're taking the exposure time into account.
Okay.
Yeah, but I didn't really think about compare it with a fixed effect.
How do you condition the individual in the Poisson? Do you just put in an indicator for every person?
Yeah.
A dummy variable. Okay. Sorry, I hijacked the conversation. Please, any more questions? Oh yes, one more.
Hi, this is FM from Pharmacy. I always have a question about using the EHR doing the case control study. I'm thinking that if there is an inherent disadvantage or selection bias, because when we choose the control from the EHR, actually they are the patients. They are not from the general public. So I'm just wondering if this can trigger some selection bias when conduct the case control study.
I agree. I think self-control theory design, I think in a lot of occasions, it has such a stringent assumptions, right?
Yeah.
You have to self-harm to be included, but you cannot be fatal, right? Because if a person died, the person will not be counted in the exposure period. So there's some such complicated selection procedure apply. I think it already jeopardize the generalizability. So I agree. I think this is actually the first study I used self-controlled, and I didn't really entirely rely on that. Still, because I think cohort analysis and self-control, they're answering different questions. None of them are perfect, but yeah, we need both. Yeah.
Another question is, I noticed that you are using the suicide as one of the outcome, right? And as we know, the assumption of SSS, there's one that your events should not alter the probability of the observation. So do you, in your study?
Suicide has already been excluded.
Oh.
And our main analysis will only consider the first self-harm.
Self-harm, okay.
The self-harm also is, one self-harm will affect the next self-harm, right? If you self-harm once, highly likely you'll have self-harm second time. So again, another selection. Only people have only one record of self-harm.
Got it. Thank you.
Thank you, everybody. Thank you so much, Dr. Lo, for an excellent presentation. It was really informative. I learned a lot. I'm sure everybody here learned as well. Thank you. I'd like to give another round of applause. Join us for next month's seminar. Sorry, I can't remember the exact date, but it'll be on urban research methods. Thank you so much.